I was spending time in an emergency ICU, and in that emergency unit, they also had pediatric emergency. And we were at that place. We were seeing a lot of patients, specifically neonates, coming to neonatal ICUs. But till the time they reached to these neonatal ICU, they were not receiving proper breathing support. So either they were coming almost brain dead or with severe hypoxic injury, or they were not even surviving that path. That's where clinicians and nurses there gave us a thought that how can you enable the access to the gold standard respiratory therapy at the point where birth is happening. And we started looking at this problem from the core and then built this technology. We call it SaaS. But here, as part of this presentation, I will not talk about the product much because that's there in the marketplace. We'll talk more. But here we will talk more about the challenges we face while we started scaling it up. Today, around 2,000 of these devices running across India. We are in sub-Saharan Africa. And the current photo which we are seeing is our 5th version of it. And 5th hardware version. Software, I'm not even counting right now. So how many changes we had to make. So I'm just going to share our experience with one of the projects we have done with the help of USAID and Gates Foundation, and what we learned about enabling respiratory support, specifically in low resource settings. So the project geography was selected was Assam. Assam is a state in northeastern part of India. It's a combination of hilly as well as flat surfaces. So it's a big part of it is in Himalayas. So it looks beautiful, amazing for tourists, bad for giving patient care because you can't go. There are many places where transport is not available properly. There are few islands where the only way you can go is through boat. But still births are happening there. Still there are issues of respiratory distress. They have really high neonatal mortality. They are second in India actually in terms of neonatal mortality. And that's where the whole state did an analysis and they selected SaaS as one of the solutions they wanted to try out and deploy it. They went to the USA, Gates Foundation came in picture and said that can we do one of the largest respiratory distress management program and study it. So they deployed in each and every public hospital of Assam. So they have around 32 districts, medical colleges, district hospitals. Everywhere this respiratory support system was deployed. We were only supplying the technology. Then they designed a full training program around it. And the full objective of this whole program was first to strengthen the whole system to provide respiratory support. The second thing, then study the impact of this respiratory support on the neonatal mortality and other outcome. And the third and the most important thing, because we all know this as a technology, as a solution, it works. But why it's not getting implemented, why people are not using it, what are the real barriers of implementation of a program like this. So this is how the district looks like. We had 307 of these SaaS devices deployed. We covered almost the whole state. There were few places where their SNCUs and ICUs were non-functional, so we were not able to deploy it. It's in medical colleges, subdivision hospital, as well as in district hospitals. So the first thing after the deployment, when technology got in, because what we realized, technology is the least important part of this. The most important part of this, especially for nurses, to know what is the value of it. Because one big issue we saw there, nurses said, I'm treating my patient from last 20 years. I'm doing fine, nobody's complaining. So why you are bringing a new thing? I have to learn it. Give me a reason why. So that's where the training program, which is designed by Dr. Harish, he designed it for the end-to-end respiratory distress management, not a CPAP program. What it made, they started learning that, okay, CPAP plays one important role in it, and that's where they started learning that how we can do the full respiratory distress management program. And if you see, based upon our survey, a big chunk of nurses wanted both technical as well as clinical training. None of them are fine with saying you only provide us technical training. And a big chunk of them, we had the multiple rounds of training. So it's not just the one, but we were there almost we had the target every week one of our person has to go to each of these hospital and provide the full-fledged training. It also leads to the sustainability, because more they use, the more they are going to use the consumable, so we can sustain that whole model in terms of economy as well. So this is in terms of technology adoption overview. There were few medical colleges which were using the traditional CPAP, but because of usability of our product, it almost replaced all other CPAP. So now most places they are only using SaaS, but it's again not the technology, it's the design and usability which has made it possible. And this is the success rate we had. We are close to 5,000 patient data we have. I'm still figuring out with the government how we can publish it and get all the approvals to get it in good journal. But we had got 69% success rate in CPAP. And other thing you will see, it grows. And it grows, I'll show you my last slide, which is the data. It goes quarter by quarter. And the reason behind it, even though we had deployed all the devices in Q4, but the training and the people becoming comfortable with the technology, that grows like that. So then mortality goes down and your discharge rate goes up. But it all about the training, capacity building, and the support which has given to the people, and people start becoming comfortable with the technology. This is the last thing about the barriers we have seen: human resource, infrastructure, equipment issues, management response, because many times NICUs are not the priority of the overall healthcare system of the whole hospital. Rarely you will see a pediatrician being the chief medical officer. So mostly those are surgeons or other medics. So NICU is not part of their big thought process. There was preference about this, why they use the SaaS, but that I'm going to skip. But then again, the training and the most important thing, supply chain management also makes really big change, because we got support from USAID. We were able to invest our people to set up that whole supply chain. So then hospital had the tenders in place, hospital had all the pieces of procuring continuous supply of consumable was in place. It took us more than a year to get that done. Yeah. So this is a path forward. I know I'm timed out, so if any question you have, I would be happy to answer. Device is there in the marketplace. It will be here for next few more days. If any of you want to just try it out, see how it is, and if you want to get it in your setup and want to do any trial testing on this, we are open for that.
I noticed in one of your last data slides, everything seemed to go in the expected direction except leaving against medical advice. Can you tell us a little bit about what you think was driving that?
So many places, it's a trust issue with the hospitals. So back in India, because we have public hospital and the private hospitals, many times they don't trust the public hospital setting, and they take them against the medical advice, go to the private hospital, but we don't know where they went. 99% they should go feed into the medical colleges, but it didn't go to the medical colleges.
Okay, thank you.
Hi, thank you for your presentation, and it's nice to see the success of a device being driven by training. There's a slide you showed two different graphs. One showed high technical, the other showed low technical. Can you explain the difference, please?
Can you
the technical part, there was a slide which had graphs. One showed high technical, and then one showed low technical. I didn't understand the difference. And is the technical training of the device, or also when it comes to troubleshooting and maintenance? Before that, there. Proportion of trained and then distribution of trained. Yeah.
So that we didn't train them on how to do troubleshooting and other stuff. That's training is only provided to technician, but most of these hospitals didn't have any technician. So all technical support in terms of managing the product, if any calibration, any breakdown, our team was doing. For us, technical means it's still how to use the device, how to set the parameters, and if any circuits or any alarm comes, how to manage that.
Okay, just a follow-up. For sustainability, are you planning to do that? Because you won't be there forever.
So that's how we had designed our sustainability model. We want our people to be there and drive usage with the consumable. With that consumable, we fund them. So it just becomes a sustainable model for the local people.
Thank you for a great presentation. I was just curious about your comment about strengthening the supply chain. You said that it took a year of doing that. And I was just curious if you could elaborate a bit more about what you did in order to strengthen the supply chain and whether or not it was integrated across all newborn commodities, or was it just for CPAP? And if it was just for CPAP, or even if it was for all commodities, how was it integrated into the existing supply chain mechanisms that were already in place in the state? Thank you.
Yeah, that's a great question. And as I was telling, we got one advantage there where the capital or the device was funded by USAID. So we had to lobby with the National Health Mission and had to make them create a separate budget for the supplies related to the CPAP. And that separate budget, because it was approved at the central level, each and every SNCU can just ask for the central store. They would have already procured it and then just supply it to the hospital. So because we work at the central level, it just became easy for each and every hospital to purchase consumable continuously. And again, because our team was there, many times they were keeping a stock that, oh, your consumables are going to get over. Why don't you place an order to the central supply unit?
I just want to follow up on June's question. So I love the fact that you did technical training, but I just wondered what the rationale for not doing the training on troubleshooting with the end users on the ground. Because as has been said, you're not going to be there all of the time. There aren't the biomedical engineers and technicians there. And clinicians and nurses are just as important for maintaining the lives of those pieces of equipment as they are for maintaining the babies, because without those equipment, they won't be able to save the babies. So I just wondered why you had made the decision not to do the basic troubleshooting as part of that training when you started, because then you sort of hit the ground running and it enables you to leave. But now you're going to have to go back and do further training to basically sustain the use of those pieces of technology so they don't end up in the technical graveyard.
Yeah, that's a great question. We had a lot of discussions around it. So what I was talking to her about is a bit more engineering troubleshooting, not the basic troubleshooting. So managing basic alarms, because with the fully electronic system, there are many things which we can control through alarms. So if you get basic alarm, they know how to manage those alarms. If they know the basic troubleshooting, they can do basic troubleshooting. But if they have to replace components, if they have to replace anything, that we were not providing them. It also because of the workload they had earlier.
Yeah, so it's not about the troubleshooting with alarms, because that's clinical.
Yeah.
This is actually, I'm talking about the technical. So I am talking about the technical, because there are basic things which clinicians and nurses can do to maintain the longevity of devices. And it's about caring for those devices. There are obviously going to be things where we do need the biomedical engineers and technicians to step in and do the next steps. But there are things, and I'm saying this as a clinician, there are things which actually clinicians and nurses can do to keep those machines alive. And they are technical things. And so I wonder whether, as you move forwards, that you think about what are the basic technical things which the clinical team can do to ensure the longevity of that device. Because then when you're gone, they can do those basic things and they know when to escalate to the experts for the next steps. And that's where June and I are both coming from. We're both coming as a biomed and a clinician who work together on devices and teach people about devices. We're saying, do the troubleshooting, the technical troubleshooting as well. And that's where our questions are coming from.
Yeah, I agree with you. Only in this project, it was a conscious decision because we had a team, or we had a plan to put a team there. So we didn't do it. And other big challenge we had is also, there are on most of these places, 10-bedded NICU, just one nurse. And they had to do documentation. So many of them didn't they said, whatever you are giving is more than enough because I have 100 other part to do. But if somebody is happy to take that training, we are happy to provide them. We have modules already created. We have YouTube video on how to service the whole device, which is accessible to everyone. But yeah, I take your point. It's a good suggestion.
Okay, so we've got time for one more quick
Yes,
question.
this is just a quick question. Thank you so much for a wonderful presentation. I love how the device you described is agnostic to oxygen source. When thinking about your experience in rolling this out in this state, what was the heterogeneity of that oxygen source? And can you talk a little bit about the supply chain for that as well? Thank you.
So when we started, government told us that we got money from World Bank, and each and every place we have PSA plants running. We went on installation, just 3 of them were running. So, and many of those which were running, the oxygen, as I was telling you, it's a management thing. The oxygen supply, the priority was OT or going to other surgical side. Then many times you don't get the supply to an ICU at all. And they said, you guys manage, you guys have concentrator, you guys have something else, priority is surgeries. So we got oxygen concentrators from 5 liter per minute one, we got oxygen concentrator 10 liters, we got oxygen cylinders of, again, different sizes and pressures. And some places oxygen line was working, but not giving the FiO2 which is required. Few places, everything was working. So that was the, but if I had to break, it was 10% places where everything was working, 90% they have to they had to make changes. Some of those places, I was telling you the way we changed the software, it's a place where a lot of mining was happening, and we didn't know that. That mining, even though it was a high quality PSA plant, the particles from that mining, or it's a coal mine, those coal particles were going inside the oxygen line and getting into the system, which sitting in Bangalore in a nice air-conditioned hospital never thought that something like this can happen anywhere. So some of those challenges we actually started learning when we started deploying it. Then we added filters, we added more algorithms to detect these kinds of problems.